For those of you who may have not heard me the first time, my name is Ann Chiang. I'm a medical oncologist and I specialize in lung cancer. Um, I'm an associate professor here at Yale and the Chief Integration Officer and Deputy CMO for Smilow Cancer Hospital. We've got a great lineup tonight. We're focusing on lung cancer screening. And I will say that they're just, I know this will probably be covered tonight, but there's a lot of optimism right now for lung cancer in all areas and domains. I mean, the incidence and the mortality is going down. It's improving. In 2010, there were about 3 drugs available for molecular targets, and now since then there are 30 additional drugs that are available for molecular targets or immunotherapy. So it's really changed, and I will say that, you know, I've been here for about 10 years, and some of my patients that I met when I started and put on clinical trials are still around and come to visit me in clinic. So it's a really wonderful area of lots of research going on, lots of excitement, and we're going to share some of that tonight, and specifically around lung cancer prevention and screening. So let's start with Dr. Lee. Dr. Lee is an assistant professor of clinical medicine, and he's the medical director of the Smilow Cancer Hospital Care Center in Greenwich. He received his medical degree from New York Medical College and then his residency at Columbia Presbyterian, did his fellowship at NYU, and has been taking care of patients with thoracic and hematologic malignancies for many years now. In 2021, Dr. Lee was named a top doctor by Connecticut Magazine and New York Magazine. Dr. Lee is going to set the stage for us, and I will hand it over to him at this point. Sung?
Thank you very much. And it's my pleasure to be here speaking to you all tonight. As Dr. Chiang has said, for thoracic oncologists, right now is a really exciting time. Our treatment modalities have improved so much, and our patients, frankly, do much better than they've ever done in the past. But, you know, I want to start tonight with some statistics, and some of these statistics are rather sobering. Lung cancer is the 3rd most common cancer in our country by incidence. It is estimated that in 2021, there were approximately 235,000 new cases. However, it unfortunately has a distinction of being the most lethal cancer. It is estimated that approximately 131 people have passed away from lung cancer. So it's a deadly illness, and treating it effectively is quite important. But so is perhaps preventing it and detecting it early. Of all the 235,000 new cases, approximately 18% of the cases will be diagnosed at early or localized, what we would refer to as a stage 1 disease. Another 22 to 25% of the patients will be diagnosed at regional, typically what we refer to as stage 2 or stage 3 disease. And unfortunately, over 50% of the patients will be found to have very advanced or distant stage 4 disease. And the reason why the staging matters so much is that when you look at what we call the 5-year survival, there's a stark difference between whether a person is diagnosed very early or diagnosed very late. Again, just to throw out some numbers, and these numbers may be a bit dated, especially with the newer treatments that we have. For those of us who are diagnosed at very early stages, when the disease is localized, so survival is greater than 63%. For more localized disease, it's about 35%, a bit higher. However, for those of our patients with distant disease, the survival is pretty low at approximately 7%. Again, as the treatments improve, we expect these numbers will improve over time. But still, if you look at the difference between a very early stage cancer and a very late stage cancer, then you can tell, based on the incidence, we're talking about huge number of lives, between an early and a late stage cancer. This, I think, is the reason why screening for cancer and diagnosing these cancer at a very early stage, preferably stage 1 disease, is so important. And as Dr. Chiang has said, it's very exciting. I've been practicing medical oncology in this community since 2000. And I remember when the first of the targeted therapy, gefitinib, by the brand name of Iressa, first came out on the market in 2002. And as a matter of fact, I got the very first patient in Greenwich Hospital on that medication. And since then, these targeted therapies, and for those people who do not know what that means, unlike conventional chemotherapy where we are targeting rapidly growing cells, hopefully mostly cancer cells, and that's what traditional chemotherapy have done, the targeted therapies specifically target singular mutation or abnormalities that the cancer cells may possess, and thereby making them much more sensitive to the effect of the medication, as well as less toxic. So since the development of these targeted EGFR therapy, as Dr. Chiang has said, now we have more than 30 new similarly targeted therapies. So we have a great deal of optimism about long-term prognosis in lung cancer patients. However, as many of you know, if we can detect cancer at the earliest stage, many of these treatments hopefully won't be necessary, and that people can live longer and healthier. So with that, I'd like to introduce Dr. Justin Blasberg, our thoracic surgeon, who is leading our lung cancer screening program.
Thanks, Dr. Lee. And I think that it is sobering, and it's something that we are taking very seriously. But I think that especially the new advances in immunotherapy are where we're teaching our immune system to recognize cancer cells. There's a lot of excitement as to whether or not we can have some really extended responses in our patients, even with metastatic or disseminated disease. So, okay, so Dr. Blasberg is an associate professor of surgery, thoracic surgery, and he's the director of the robotic thoracic surgery program at the Yale School of Medicine. He earned his MD from Albert Einstein and completed his cardiothoracic training at the Mass General Hospital in Boston. His practice includes minimally invasive and open management for diseases of esophagus, lung, mediastinum, chest wall, thoracic outlet, and the diaphragm. He has a particular interest in benign and malignant diseases of the trachea and performs the majority of his surgeries when possible in a minimally invasive fashion. So he also is the physician medical director and lead of the lung screening program at Smilow Greenwich, and I will turn it over to him. Justin.
Thank you. Let me see if I can share my screen. Is that
Not
working?
Yet. Not yet.
Not yet? How about now?
There you go. Perfect. Thank you.
Okay, great. So good afternoon. My name is Justin Blasberg. I'm a thoracic surgeon here at Greenwich Hospital. I wanted to thank this audience for giving me the opportunity to talk about lung cancer screening, including our new screening program that is now fully up and running here. Just make sure I can advance the slides. I can. I think Dr. Lee touched on some lung cancer facts, but I'm going to review some of them as well. Lung cancer is the #1 cancer killer in the United States. And although even this week or the week before, the American Cancer Society released new statistics on decreasing cancer mortality, especially in lung cancer, this still remains a very big problem within our community, and it's killing patients by more than 2 to 3-fold compared to the next most common cancer by gender. We also know that part of the reason that lung cancer is so fatal is that most patients have advanced disease at the time of diagnosis. Only about 15% of patients in 2018 had truly localized disease, which you can see in these small bars. I'm hoping you can see my arrow. Can you see my arrow?
Yes.
Okay, great. Which had truly localized disease, and an astonishing 50% of patients presented with metastatic disease at the time of diagnosis. When we think about 5-year cancer or survival statistics for surgical resection of stage 1, those 5-year survival statistics range anywhere from 80 to 90%. And then for stage 3 patients represented sort of in this regional category, only about 12 to 41%. Stage 4 patients, 5-year survival is close to almost 0%. And so clearly there are opportunities in the prevention and in both prevention and screening to improve on these statistics. Although the advertisements showing either glamorous celebrities or doctors smoking are long gone, and over time the prevalence of smoking has gone down in older adults, there are alarming rates of smoking in our younger patients and our younger population, including teens and younger adults. And there are a sustained population of smokers in the state of Connecticut and our region that will continue to contribute to lung cancer, to the lung cancer cases that we manage. The rationale for lung cancer screening is rooted in the idea that patients don't develop symptoms until they have advanced disease. And unlike prostate or breast cancer, there are no physical exam findings. Unlike there is no colonoscopy for colon cancer. And you can't just do a bronchoscopy or a procedure where you look into the airway and effectively screen patients. Early on, the interest in lung cancer screening was really explored with chest x-rays alone. Come into go to the radiology center, get a picture of your chest, and then see if you can find any nodules or abnormalities. And really, studies over time have shown that this isn't a very sensitive test. I've also often found myself when I'm reviewing a CAT scan for a patient who has lung cancer, I look back at their chest x-ray to see if I can sort of see what we see on the CAT scan and see if I can identify that on the chest x-ray. And oftentimes I can't really find that abnormality. And so we know that chest x-ray alone isn't really a great test. The best evidence for lung cancer screening using low-dose CT scans actually comes from a trial called the National Lung Cancer Screening Trial. This was published in the New England Journal in 2011, where lung cancer screening with CAT scans was actually associated with a 20% reduction in lung cancer-specific death compared to chest x-ray alone. Another way to look at this, the trial results, is to focus on the numbers that matter, because this isn't just about screening patients or identifying nodules and just taking them out. There's risk to consider in addition to the benefits. So top left, in addition to the 20% risk reduction for death in the National Lung Cancer Screening Trial, the study calculated the number needed to save a life. So the number of patients needed to be screened in order to find the lung cancer was 320. And I'll show you in the next slide that number is actually pretty low. The absolute risk reduction means that you have to screen about 1,000 participants in order to save 3 lives or to avert 3 deaths. And then in terms of the number needed to harm, which includes the number of unnecessary surgeries or potentially the risk associated with radiating so many patients and cancers that can form as a result of radiation, that number was also very, very low. The number needed to harm was 3,800 scans to harm 1 patient, which still sounds like a dissatisfying outcome, but that in terms of screening tests, that's a very low number. And sort of when we compare these numbers to other accepted screening modalities, common things that we all either partake in or have family members that partake in, the number needed to save a life in lung cancer screening is only 320, whereas in mammography for breast cancer, it can be anywhere from 800 to 2,000. And you have to do 1,250 colonoscopies to find a patient who has a colon cancer. However, even with that endorsement, there's still been a very slow rate of adoption of lung cancer screening, which can probably be attributed to a lack of general understanding of the criteria that defines the patients that should be screened. The patients themselves may not understand the value of lung cancer screening, and the medical community themselves up to date may not have really understood the value of lung cancer screening and just the particulars of the lung cancer screening trial as a single study which showed a benefit to screening and leveraging that single study and those results against things like infrastructure, organization, and the follow-up that's needed to start and then maintain a lung cancer screening program on a large scale. Since the NLST study, there have been a number of other studies, which we won't go into tonight, but a number of other studies which have reiterated these findings and reinforced the idea that this is an important place for us to focus our energy and our attention. So what is the overall benefit of screening? Clearly, the detection of lung cancer when it's early and most curable is associated with a reduced risk of dying from lung cancer. There are 7 million Americans who are estimated to be eligible for lung cancer screening. And if you apply the results of the NLST trial, the trial I just showed you, to those patients, there's an opportunity to save about 22,000 lives. However, when I last looked up the data on compliance with screening guidelines, only or less than 4% of patients who are eligible for screening in the United States have actually been screened. And so why might that be? In clinic, we discuss with patients the potential risks of false positives. Over 95% of nodules that we see on these screening CT scans themselves are not actually even lung cancer. And although the radiologists are really good at commenting and classifying nodules based on standardized criteria that Emily's going to get into in a little bit, a percentage of these patients will go on to get biopsies or even surgical resection and ultimately end up having benign disease. There's also a risk of false negatives. So a high-risk patient that has a negative screening scan may not be motivated to undergo additional screening. And there's clearly a risk that a downstream lung cancer could form in a 55-year-old patient who's a heavy smoker and had a negative screening test. The risk of radiation exposure is really low. Patients are often worried about this. The exposure is about 20 to 25% of a standard CAT scan, which is equivalent to about 12 chest x-rays and similar to about 6 months of background radiation in our community. And so since the introduction of lung cancer screening in a sort of a mainstream environment, patients often ask these questions. And so I think, this is important information to keep in mind. The other question often asked is, do insurance companies cover this? And since the introduction of the United States Preventative Task Force recommendations for lung cancer screening, insurance authorization has also been less of an issue. So when we inform patients on what these results might mean, we try to break it down into easy to understand categories. Clearly, a negative screen means there are no significant findings, no identifiable nodules. These patients can be followed with annual screening and annual scans if they choose to do that. A positive screen that's indeterminate for lung cancer represents probably our most important group, especially when it comes to compliance with future scans. These are patients where there's an identifiable lung nodule, in some cases multiple nodules, and although the majority of these nodules are not in fact cancer, these patients need close follow-up because some small percentage of them will grow and ultimately need surgery or a biopsy. And so that's an important group. The positive screen suspicious for lung cancer represents another important group. These are patients who have their first or second scan. Nodules are highly suspicious for lung cancer, and they move immediately into not a screening or a surveillance pathway, but into a diagnostic and treatment pathway where they undergo staging and testing, and we get a sense of how much treatment a patient might be able to tolerate, and then think about treatment options like surgery or radiation therapy. So who qualifies for this? The original Preventative Task Force recommendations from 2013, which we can see on the left side of this picture, targeted patients who were between the ages of 55 and 80, patients who had a 30-pack year smoking history, and patients who were either current smokers or who had quit within the last 15 years. And then last year, these recommendations were revised to offer screening to a much larger population, now age 50 to 80, only a 20-pack year smoking history, and the same considerations for current or former smokers, either a current smoker or somebody who's quit within the last 15 years. With these extended recommendations, there's a predicted 7 or so million extra people who now are eligible for screening. And so these were important changes and the reason we're giving this talk tonight. I think when we look deeper into our local patient population, And this is a breakdown of newly diagnosed cancers and cancer deaths from in the state of Connecticut. So slightly older data from 2010, but still relevant. We can see similar trends to national statistics. While lung cancer on the left, you can see here in green only represents 13% of the diagnosed cancers in the state of Connecticut. We can see on the right side, it represents 27% of cancer deaths. Fairfield County continues to be one of the most populous counties in the state of Connecticut. It's got almost 1 million people in it. The population of every town in this region has grown since 1990, and that growth has outpaced any other county in the state. Our population, as most of you know, is relatively healthy compared to national averages. Most of our patients have health insurance and therefore access to care. And although the prevalence of smoking itself is not incredibly high compared to the rest of the state or other parts of the country, the size of the population actually presents significant opportunities for us to grow our lung cancer screening program and to also help patients at the same time. I won't spend too much time on the prevalence data, but this heat map shows smoking statistics in both Fairfield County and Westchester. The darker blue means a lower prevalence of smoking, and compared to national statistics, our smoking rates are clearly lower than either the state or national average. They're also downtrending, which is great. We can see that on the top right of this picture. But I think it still reiterates the point that there's a sizable population in our region serviced by Greenwich Hospital that would qualify for lung cancer screening. That's better seen in this picture, this heat map, which demonstrates the rates of lung and airway cancers in our area. Again, darker is better. So we're doing better than the rest of the state of Connecticut, and we're doing a lot better than national averages as well. But lung cancer in Fairfield County and Westchester still remains a significant contributor to cancer related deaths in our area. So I think that's a good segue into how we look at our program, how we plan to grow our program. Emily is our lung cancer screening coordinator. She is the one and only lung cancer screening coordinator. And she's going to take over the talk and share with us some of the accomplishments that we've been able to realize with the growth of our program so far, as well as future directions.
Thanks, Justin. That was terrific. And I'll just say another word about Emily. Emily has a wealth of experience in oncology. Not only has she been an inpatient medical oncology nurse, but she's also been in the infusion setting, in the outpatient, in the cancer center at Greenwich. She's worked at Greenwich for 6 years. She's an oncology certified nurse. And she's just perfectly the perfect person she's been in this new position working on the lung cancer screening program for about almost a year, and she's the perfect person to do it. So I'm going to hand it off to you, Emily.
Thank you, Dr. Chiang. So I will share my screen. Can you guys see my screen?
I can see your email.
Probably not a good thing to share. All right.
Perfect.
Okay. All right. And again, my name is Emily Kopas, and I am a nurse practitioner and lung cancer screening coordinator for a program here at Greenwich. And we officially started our program at the end of June. So the mission of our program is to provide an integrated, comprehensive, interdisciplinary lung cancer screening program. And we are comprised of a team of pulmonologists, chest radiologists, thoracic surgeons, thoracic oncologists, smoking cessation specialists, and nurse practitioners. It is important to emphasize that lung cancer screening is not solely just an imaging test, but it really is a process that needs to take place within an organized system. And I'm going to be sharing a little bit about our process here at Greenwich. So just to reiterate some of the statistics that Dr. Lee mentioned in the beginning, is that lung cancer is unfortunately on the rise and affecting both men and women. And of all of the people that it's affecting, only 16% of lung cancers are diagnosed at a localized stage when it is most treatable. And the 5-year survival rate for this group of people is 56%. And in contrast, this is compared to 47% of cases that are not caught until a late stage. And the survival rate is significantly lower, approximately only 6%. And one of the most significant ways that we can really improve the overall survival rate of lung cancer, of patients that are affected with lung cancer, is through screening and early detection, which is where lung cancer screening comes into play. So I just wanted to show you a picture of a chest x-ray versus a picture of a low-dose CT scan. And Dr. Blasberg mentioned this in the NLST trial, which is one of the first trials that took place that led to lung cancer screening being approved. And as you can see on the left, that is an example of a chest x-ray. And it is not quite as clear as the picture on the right, which is the low-dose CT scan. On the left, we rely more so on shadows for interpretation, where the picture on the right is a lot more detailed. We can see the overall vasculature of the lungs, as well as it gives us a nice dimensional picture of what the lungs look like. And we look for these little spots that can appear in your lungs, and we refer them to as nodules. And depending on the size, we might not be able to detect them on a chest x-ray, whereas a CT scan, they're able to be visualized a lot better. And even though they may be small, it is really important that they get the proper follow-up because they can lead to lung cancer. And again, Dr. Blasberg mentioned that USPSTF recently updated their guidelines. And again, USPSTF stands for the United States Preventative Services Task Force. And they, most recently in March, they expanded the age as well as the PAC year, smoking history. So they extended it to include those that are between the ages of 50 and 80. And they've also expanded the PAC year smoking history to 20 PAC years. So what this means is that it's essentially 1 pack a day for 20 years, or for example, it could be a half a pack a day for 40 years. And this does double the people that are eligible. And most commercial insurances right now are actually covering this expanded guidelines. However, CMS, which is Medicaid and Medicare, have not yet adopted these guidelines. It is predicted and hopeful that they'll make an announcement soon. We have received orders for people that do meet this new criteria, that do either have Medicaid and Medicare, and they have not yet been scheduled because we're awaiting on CMS's announcement. But as soon as they make their announcement, which hopefully should be really soon, we will make sure to get them scheduled as soon as possible. And this is CMS's statement when they first approved the first set of guidelines. And they stated that they approve lung cancer screening. But in addition, all patients that have a lung cancer screening, they require them to also have a shared decision-making visit, which I'm going to be talking about in the next slide. So a shared decision-making visit, we have been having all patients that are screened through our program to have a visit with me. And it can either be over the phone, it can be a telehealth visit, or they can even come in person. And I've had a variety of different visits. And we go over their eligibility criteria just to make sure that insurance does cover their scan. And we have a detailed discussion of an individual's benefits and risks of screening that Dr. Blasberg mentioned earlier. And we really try and individualize this to make sure that we are weighing the benefits and risks of screening, and that we understand that depending on the person, that might be different. And I also offer them a personalized lung cancer risk evaluation. And I use the Tamamagi risk calculator. And what it does is it gives a nice estimation of a patient's risk of developing lung cancer in the next 6 years. And a variety of different factors influence this score, including age, smoking history, family lung cancer history, and a variety of other factors. And again, it's just an estimation, but it is nice to kind of put into perspective a patient's overall risk. And during this visit, I also try to really emphasize how important it is to adhere to these annual screenings. And this is really essential for a positive outcome for individuals, because unfortunately, lung cancer can grow really quickly, and we try to catch it before it spreads throughout the body. And when it's in its early stages, when it is the most treatable and the overall survival rate is the best. So I really try and emphasize this as much as possible during these visits. And all patients that are part of our lung cancer screening program are able to partake in the Yale smoking cessation program if they are interested. And all patients that do come through our program that are new, I do mail them a little folder of just some general information on what lung cancer screening is, as well as any common questions and my contact information, as well as Dr. Blasberg's. So the smoking cessation program has been really beneficial for many patients, and this can take place over the phone or via telehealth. And patients are offered free smoking cessation products like nicotine patches and lozenges. And patients actually do have the opportunity to be compensated for their participation, which is great. And a really key part of this is they're offered support through counselors, which does make a significant difference for many people. And again, this can be all over the phone. So you don't have to commit to driving to there to get, the counseling. And again, so what does this Lowdose CT scan look like? It takes no more than 5 minutes of your time. There is no contrast dye. There's nothing you have to drink. There's nothing that has to be put in your arm. It is very quick. As you can see, there's a picture of the CAT scan. It is open. It is not closed in like an MRI. And they will basically just ask you to take a deep breath and hold your breath for a couple of seconds, and then they'll take the picture, and that is it. The radiologists do utilize a lung rad score, which I'm going to be talking about, to read all of the scans. So lung rads, and this is approved by the American College of Radiology as a reporting system that standardizes all of the scans as well as the management for all the screenings that are performed. And the scans are on a scale of 1 to 4. They're assigned a value, and it basically depends on the size and the density of the nodules that are found. And again, nodules are little spots in the lungs. A 1 and 2, the recommendation is to follow up in a year. And in a 3 or a 4, the recommendation varies. And in this category, it's a little bit more suspicious for lung cancer. So we want to repeat these scans a little bit sooner than a year. So the recommendation is usually 3 or 6 months to follow up. And again, the scoring depends on the size and the density of the nodules. So most recently, our lung cancer screening program at Greenwich, we have completed 52 screenings. There are a couple of screenings in the work queue that will be scheduled. The majority have been lung rads 1s and 2s, which is great. There have been a couple of 3s. And with our system, there has been a really nice dashboard that has been built out for us with the help and a lot of time that's been put in by the IT and Epic team. And this dashboard, it works with Epic, which is our electronic medical record. So all patients that are screened, we're able to see the demographics of individuals that are screened. We're able to see all the lung cancer screening detected cancers, as well as any patient that is overdue for their follow-up scan. And it actually even categorizes patients that are at lower risk with the 1s and 2s, as well as the higher risk of 3s and 4s. So we're constantly looking at the dashboard to make sure that patients receive follow-up in a timely manner. And if for some reason a patient is overdue, we will then go ahead and either send them out a letter to remind them or call them and try and have a discussion if there's any barriers in place that might be preventing them from coming back to getting scanned. We try and work through that with them to make it as successful for the patient as possible. And I would be remiss without mentioning our other screening programs within our delivery network. In addition, at Greenwich, we also scan patients at the Long Ridge Medical Center in Stamford. There's also established programs at Bridgeport Hospital and in Trumbull, in New Haven, as well as Lawrence Memorial. And all of these other locations have been instrumental in helping us establish our program here officially at Greenwich. Polly in New Haven has been tremendously supportive and helpful, as well as Megan in Trumbull and Karen at Lawrence and Memorial. So we owe a lot of thanks to them for helping us get our program officially started. And we also meet weekly with all the different coordinators, and with the other programs, you meet weekly to discuss any challenges that might come up, or we're constantly looking for ways to improve our program and to expand it to as many people in our communities as possible. And just in case there's any providers on the call, there are 3 essential orders that can be placed for a lung cancer screening low-dose CT scan. And it is initial, obviously, that's for the first scan. Subsequent is for the annual. And the nodule follow-up scan, that is for any lung RADs 3s or 4s with a recommendation of 3 or 6 months. There is an order form for providers that are not on Epic that I'm happy to provide. I'm going to give my contact information at the end, so feel free to reach out to me if you're interested in an order form. I also just want to mention too that all of these low-dose CT scans, it is essentially the same scan, that it's the same scanner that you would get for a regular CT scan, but they just lower the radiation settings on the scan. So opportunities for growth at Greenwich Hospital, which is our essential goal. There is a lot of room for emergency room encounters as well as our clinic. We actually, the most common source of our referrals is from our clinic at the hospital, which is great, as well as Epic. This is a work in progress, but we're working with the IT team to develop a way that could possibly alert providers for patients that are eligible for screening based on their age and their smoking history, and if it could benefit patients. So that's a work in progress, but it could lead to a lot more referrals and getting the word out for patients that could be eligible for the program. And here's my information, as well as Dr. Blasberg's. I highly encourage you, if you have any questions, which we'll have time for at the end of this, but anytime, feel free to either email me or call me. I'm happy to discuss and try and provide our program to as many people in our community as possible. And that, I guess, leads us to some time for questions, if anybody has any.
Yeah, there are a couple of questions that have come in through the chat, and I'm sure there will be more. So I'm going to direct this either to Dr. Blasberg or to Emily. There's a question from your perspective: is it prudent for people who have been exposed to secondhand smoke to have lung cancer screening? And there's one other question about screening for ages under 50, for example, in your 30s or 40s. Dr. Blasberg, you want to start?
Sure. I think that's a good question, and it's a challenging question. The data doesn't support screening never smokers, and secondhand exposure, while that could be significant, technically those patients are never smokers. I think that's going to change, and the data for that change is probably, we've seen in certain populations around the world where lung cancer prevalence, the occurrence of lung cancer, is much higher. So in certain parts of the world, like in Japan or China, where their rates of lung cancer are much higher, and including not just because they may smoke at a greater rate than we smoke here, but they also are, there are populations there that have a higher susceptibility to genetically driven lung cancer. And so I think from those populations, there has been data supporting lung cancer screening in what we would consider never smokers. And so I think this is a process where there's an evolution, and patients will be considered at higher risk, not just because of age or smoking status, but also things like genetic susceptibility or family history or secondhand exposure or occupational exposure or things like environmental exposure, radon exposure. And so I think we'll see that in time. The current guidelines don't support screening in that situation, but we certainly, especially at Greenwich, see a percentage of patients who are very interested in screening and are even interested in screening at their own expense because of their concern under those circumstances. And there are occasions where we consider screening patients like that. So it's something that it's a moving target and a good question.
Great. And actually, along those lines, here's a question. Is screening advised for an 85-year-old woman who quit smoking or who smoked from 1950 to 1978? So that's 28 years, almost 30 years.
Yeah, so similar answer in that the guidelines would say no, but I think not all 85-year-olds are, every 85-year-olds can have a spectrum of health. And for a healthy 85-year-old with a significant smoking history who's never gotten a scan before, it makes sense to me that we consider those cases on a case-by-case basis and say, what would we do with the information? How would we act on it? How would that, help the patient? And so I would say that just being 85 alone wouldn't be an absolute contraindication to lung cancer screening. And it's something we would consider, in a patient who is motivated to want to pursue that.
Great. I've got another question here. How many % of non-smoking develop lung cancer? And maybe I'm going to direct that to Dr. Lee, because we talk about smoking being a risk factor, but as many folks may know, there are also never smokers who develop lung cancer. So Dr. Lee, you want to comment on that question?
Well, you struck me with a tough one. So the real answer is yes, there are a fair number of people who, and unfortunately, I'm not sure if we got to show this actual statistics. The overall incidence of lung cancer has been declining since the 90s. Where we have seen rise are in the last few decades in women, and alarmingly so in women non-smokers. Unfortunately, I mean, unless Dr. Chiang has the data, I cannot tell you out of 100 new patients who are diagnosed, how many are non-smokers. I would have to say it still represents a small minority, but that number has significantly changed and has gone up in the last 40 or so years. And I mean, I don't think anybody really has a good explanation for why the incidence of lung cancer in non-smokers has gone up, but that is a and do you have the specific figure out of 100 people, how many are non-smokers?
I think it's around 10 to 20% actually. And when those patients develop lung cancer, we do molecular profiling, which is we look at their tumor to see whether there are specific mutations that might explain and what might predispose that patient to developing a tumor and might explain why they have that. And the other part of that is that when they do have those mutations, such as EGFR or ROS1 or ALK mutation, there are about 3 or 4 other ones, then they may be eligible to actually take an oral pill that targets that mutation. That's what we call precision or targeted medicine. And so that's actually nowadays there's technology where not only, I mean, the gold standard is still to look at the lung tissue, but you can often also take a blood sample or a liquid biopsy, which sometimes can provide that information as well. So
to the person who asked that question, I think what you bring up is a very important and a good point. That is to say that if 1/5 of all lung cancers are non-smokers, and our current screening method only in our screening criteria, only smokers are eligible, then a significant percent of people who will have lung cancer don't even have a chance to undergo a screening test. One of the things that we hope will get better is that, similar to what Dr. Chiang was saying about blood tests, over the last, let's say 20 plus years, there have been a great deal of interest in studying characteristic of protein and chemicals in our blood that can indicate very early cancers, and not just lung cancers, but other difficult to diagnose cancers like pancreas cancers and ovarian cancers. And there have been some interesting and promising results that have been reported in very prestigious journals like Nature and Nature Medicine. So, I would say stay tuned. It would not surprise me if in the next several years we have other different screening modalities that may be something that we do just with blood tests.
Or maybe just with our iPhone, right? We can do everything else with that.
Yeah, like Star Trek, he's a coder or something.
There's another question here. If you don't test positive for mutations, are there new, less toxic chemo treatments? And this is actually a wonderful story. Thank you for sharing it. I had, for this person, you had your right upper lobe removed 4 years ago, or more than 4 years ago, by Dr. Blasberg. Great job. And no lymph nodes were positive, and she's still okay. So in your case, you opted not to have chemo, and the annual CT, no metastasis, and that's congratulations. That's certainly a wonderful story, and that's what we're all hoping for. But yes, I think that new therapies such as immunotherapy have they do have side effects, but a very different side effect profile than chemotherapy, and often tolerated much better. And people can have very good outcomes from that. So I'm going to ask a question to Emily, and this is going back to Dr. Blasberg's, we talked about mammograms. Everybody has on their list, all females at least, and some males, gee, it's time for my annual mammogram, and it doesn't seem like we're to that point yet for our annual Lowdose CTs. Why do you think that's the case, and how do we get that message out?
That's a good question. I actually looked this up, and Dr. Blasberg gave a statistic of it takes essentially it takes about 1 in every 320 people to get screened. And it is to save one life. And it's actually more than, it takes more for a mammogram. It's approximately, depending on the age, between 470 and 2,000 to save one life, the amount that needs to be screened with a mammogram. And I think part of it is awareness. Maybe it being a newer screening measure, as they recently came out with this screening back in 2015. So that might have something to do with it. It's hasn't been around for as long, but it's also, I think it's really important to increase awareness about lung cancer screening and the benefits that it can have. And it's the nice thing about it, it is just almost as easy as getting a mammogram, in a sense that it doesn't really take that much time, about 5 minutes, if that. So maybe going to the testing centers to get screened could be a limiting factor in the amount of people that do get screenings. But I was looking it up, and there's really only 7% of all the people that are really eligible for screenings actually get screened. So there's significant room for improvement with that. So we're trying to do everything we can to spread awareness within our community, and trying to get in touch with populations that might be at higher risk of developing lung cancer.
That's a great answer. And so everybody on this call, on this webinar, if you go out and tell people about this, or if you have questions, any one of the folks on this would, myself included, would be happy to come out and talk to a group. And I know Dr. Blasberg you're just waiting to go to the malls and Home Depot, I know, to talk to folks and others as well. There was a question that asked if Greenwich was the only place where screening was available. And actually, Emily showed a very nice picture that this is across the state. And not only is it across the state, but it's something where Yale and Smilow are working together and connecting everybody so that we can learn from each other and make sure that we can, provide our best services and leverage our electronic medical records to send reminders, as Emily mentioned, and so forth. So New Haven, Bridgeport, Trumbull, Waterford, Lawrence and Memorial, as well as in Longridge and Stamford and Greenwich. So let's see. Other questions?
Can I ask a question of Emily and Justin? Can you guys comment on the duration of screening? So when a person starts on the program, how many years should he or she be screened for?
They should really be screened until they phase out of the eligibility criteria, or if a lung cancer diagnosis comes about.
Yeah, there are two groups there that you're looking for. One is first scan or second scan, where you identify something that's clearly a lung cancer. And then the second group are patients who have lung nodules that change over time, and you need to see those and compare those subsequent scans to appreciate that change, and then identify those patients who have not necessarily the aggressive, invasive, larger lung cancers, but the ones that change in a more subtle way and that can impact survival over time. And so if you look at the lung cancer screening trial and the Nelson trial and some of these other studies that really dug into compliance, they both scanned lung cancer screening trial scanned for 3 years, and Nelson scanned up to 6 years. And so the benefits are realized in the short and in the longer terms follow-up. So compliance is really important. It's not just one scan and one and done. It really is about sort of having the continuity, which is really important. It's about incorporating smoking cessation as part of that. It's about having a team that that can follow you and give you guidance.
And I think that point about the team is so important, because as you can see on this call, these are members of your team, but there are lots of other folks who add to the lung team. One of the really exciting, besides this lung screening, but exciting initiatives in Greenwich is the initiation of the multidisciplinary clinic that includes Dr. Blasberg and Dr. Lee, as well as a radiation oncologist sometimes. So I don't know if one of you wants to talk a little bit about how that was about the multi-D clinic, what that means, and how that helps patients. Oh, you're on mute.
Yeah, so I'll take a crack at it. So fortunately for us, as you know, there are many different ways of treating cancer. And at the time of the diagnosis, we have 3 different modalities and 3 different specialists. Myself as a medical oncologist, Dr. Blasberg, of course, with a surgical expertise, and Dr. McGibbon and Dr. Campbell with the radiation therapy as a potential treatment modality. And without getting into detail, depending on the stage of the disease, a person may be advised to have 1, 2, or all 3 of these treatment modalities. And at times, it is, and frequently actually, it is helpful for a patient to meet with all of the specialists in one visit, so that their care can be coordinated in a really efficient manner, with a clear-cut treatment plans that are laid out at the time of that initial visit. So what we offer are this, as Dr. Chiang had alluded to, a multidisciplinary clinic, an opportunity for our patients who are newly diagnosed with cancer to meet with 2 or 3 of us at the same time, so that we can formulate a treatment plan after one visit.
Exactly. So, I think some of the patient feedback from other areas in our network is that, what a great thing, you take one day off of work and you get to see all of your doctors, and your team is there and they're talking to each other with you. And so that is, I think, a really terrific um, offering. There's another question here in the chat. Great questions, by the way. Thank you. What is the rate of new cancers in patients who were diagnosed with a cancerous nodule treated with a partial or full lobectomy? So, Dr. Blasberg, you want to take a crack at that? You removed a cancer, and what's the rate of new cancers, the risk there? Is it higher? Is it at the same, or?
Yeah, so this is an interesting question and an important one. And so what we generally do, there's a risk of cancer coming back, and that risk is something that we generally expect to see if we're going to see it within the first 2 to 3 years, but we even expect it up until about 5 years. So there's a risk of cancer coming back, and then there's also a risk of new cancers developing in the future. And so the talk I give to all of my patients is, after you have lung surgery or radiation therapy, you get scanned. Basically, we become best friends for life. And so you get scanned every 6 months for the first 2 years after surgery, and then you get scanned every year thereafter, basically for the rest of your life. And so we're always looking for either recurrence of the old problem or new nodules, new lung cancers that can develop. What the risk of that is, it really depends on a lot of things. It's hard to pin it down to a specific number, but the point of looking is similar to lung cancer screening. The earlier we can find a problem, the earlier we can address that problem, the more likely we are to be successful long-term in treating that problem. And so the compliance with lung cancer screening, like the compliance with the scanning after having surgery or radiation therapy, is really, really important. And we spend a lot of time on that.
Dr. Lee?
Yeah, if I may just say a little bit, to answer that question, if you just have to think about what the statistics were from the very early stage, even those of us who are diagnosed with very early stage lung cancers, I'm afraid that the 5-year survival is not 100%. I mean, it's not going to be 100% because things happen in life, right? Besides cancer, but even so, you have to assume that there are significant mortality due to cancer recurrence. So this is why it is very important that those individuals become best friends with Dr. Blasberg and be followed very carefully.
And Dr. Blasberg definitely has a fan club. We have another patient who's shared in the chat that she was a long-term smoker who had finally quit smoking for a couple of years and ended up in Dr. Blasberg's office and found that she tested positive for lung cancer after a biopsy and had her surgery April 2020 during COVID. And it was early stage 1, and she part of the left lung was removed, no chemo, a 6-day hospital stay, and doing great. Just saw Dr. Blasberg for the 18-month visit. Early detection was critical for her. She said sought that out. So that's you can't get a stronger statement than that story or the patient. So Justin, any words on that?
No, it's I'm glad to see. I sent out gifts to as many patients as I could to show up tonight. So I'm glad to see some of those actually were received. But no, I think these are important points, and thank you for sharing your story. It's really important. These are great examples of why things like lung cancer screening are critical in our community. And I think we have a really strong program in our network in New Haven and in Bridgeport and in New London. And with Emily's help, I think we plan to grow out the Greenwich part of that program to that same level. And I think, we're hoping to have more stories just like these to share. So that's our goal.
And as I said at the beginning, there just have been advances for lung cancer for early stage, for metastatic, for locally advanced disease. Just this past year, two drugs were approved by the FDA that were led by, or that were the results of trials, clinical trials that were led by Yale investigators. And one of them was to give immunotherapy after surgery, and one that's after chemotherapy and then immunotherapy, and one was if you have one of those mutations, the same situation that you could give EGFR directed treatment, that pill after surgery. And that those were both led by Dr. Herbst, who's our chief of medical oncology here. So we've worked really hard to make clinical trials, which is really how you change the field, available to all patients throughout our Smilow care centers in Connecticut, including Greenwich. So lots of, and I see folks, again, folks on the call who I know who have participated or are participating in clinical trials. So that's really exciting as well. Let's see, other questions? Emily, I have a question for you, and then I think we'll probably wrap up in the next few minutes. Emily, you do this clinical decision making when you talk to the patients prior to the scans. What are some of the most common questions that you might have from patients that you think would be good to share with folks on this call?
Sure. Most recently, a lot of patients have been asking, is it safe to be screened with the current wave of COVID? And we do follow all safety protocols, and it is safe as long as the individual feels comfortable. Unless it is an initial, we really try not to postpone any subsequent scan, especially if it's a follow-up for a nodule that's a little bit more concerning for lung cancer. Another common question is the scan closed? And how long does it take? And it is open. So if you are claustrophobic, this should not bother you, as it just kind of goes in with your head as the picture I showed, and your feet are exposed at the other end. And there is no IVs that have to be inserted. There is no contrast dye that you have to drink, and it takes no more than 5 minutes. So I really try and emphasize those points. And another question that sometimes comes up is about the radiation exposure. And as Dr. Blasberg mentioned, it's really minimal, especially compared to a full CAT scan. It's about a quarter of the radiation that you would be getting with a full CAT scan. It is more than a chest X-ray, but as I mentioned before, these Lowdose CT scans are so much clearer of a picture than an X-ray. So any other questions that come up, we discuss, and sometimes it might not necessarily be right for the patient at that particular time, but I always try and emphasize that when an order is put in, the patient has really a full year to get that screen if it's an initial. If it's a subsequent scan, then we try and make sure that it's a timely follow-up.
Got it. And certainly people have some fear around getting diagnosed with cancer. Dr. Blasberg, I'm going to ask you this question. What do you think is, what has changed about the way you do surgeries, the minimally invasive approach? Can you talk a little bit about how that's changed and how it's safer?
Sure. Yeah, I think over the last 15 to 20 years, thoracic surgery in general has moved to a minimally invasive format. That's small incision surgery. That means, taking out pieces of a lung through keyhole incisions. A newer version of that surgery, which is something that I do a lot of, is robotic surgery. And so it's not an autonomous robot doing the surgery for me. It's robotic instruments that go through smaller keyhole incisions, and then my hands moving those instruments in a console And so we're able to do a lot of lung surgery with these small incision formats, robotic surgery in particular, at the Greenwich campus, at Bridgeport, at New Haven. And so, we've become very facile with that. That's allowed patients to get out of the hospital faster, have decreased pain requirements, to get back to work faster. We can do that when we plan on doing that. We can do that above 95% of the time, which is really, really high. The national average is somewhere around 80. And so, we've been successful with minimally invasive surgery for lung cancer, and that's kind of our, that's kind of what makes us special at what we do, I guess. That's what makes us different. And so, between lung cancer screening and minimally invasive surgery, the idea is to try and get these things out as early as possible, and then to get patients back to their baseline, to work or home or whatever it is that you want to do with your time, to get back to that much more quickly. So that's where we are today.
Love that. Thank you. And Dr. Lee, any last words about how things have changed for your patients who have perhaps metastatic disease, but are still undergoing treatment, and the quality of their life compared to 10 years ago?
So I would say the difference has been huge. Quality of life, very important. So we've already touched upon the overall improvement in response, longevity, but the quality of life. And this is something little different, something that we would probably touch on another topic, a supportive care. Palliative services that can improve our symptoms, improve the side effect of the treatment, improving nutrition, a wellness program. These are things that Smilow offer to their patients, and I think there's something that those patients who are able to utilize do really benefit from. That is to say that lessening side effects come from improvements in the medications we have, but also a more holistic approach in treatment of cancer. Again, incorporating wellness of our mental attitude, as well as nutrition being incorporated into cancer care, I think has significantly improved in overall, not just, again, longevity, but improvements in quality of one's life.
Absolutely. Well said. Well, I think we're at the end of our time. I'll have a shout out one more time. Any other questions? Otherwise, thanks very much to our presenters. I learned a lot, and thank you to our audience for attending. Thank you very much. Great to see you, and hope we'll see you soon in the clinic or elsewhere. All right, take care, everyone. Bye-bye.
Thank you.
Thank you.